All right, we've reached the magic number of 100. Last time we had 115, so I expect a few more folks will be arriving shortly. So with that, greetings to everybody and welcome to the webinar called Client Selection, Intake and Assessment in Telemental Health. This is the third of a 6-week series on telemental health. My name is David Jefferson. I'm the Director of Training and Technical Assistance at the Northwest ATTC, and I'll be the moderator tonight. And behind the scenes, you have Jennifer Verbeck that is helping with the technology. And our guest speaker tonight is Dr. Sarah Smucker-Barnwell, and we're very excited to have her for the series. She's wonderfully informed about this subject, and so far we've gotten wonderful reviews about our presentations. I want to particularly welcome all of you that that you've come back for more than one session, but I also want to say welcome to anybody that's joining us for the first time this evening. On our website, which we'll give you access to later, which you can find previous versions of the prior webinars. Okay, before we get started, on the next slide, I want you everybody to know that here at the ATTC, we believe that language matters, words have power. We strive to be culturally informed and inclusive and value your feedback while and how we're doing. And you will see our email address posted several times, and we invite you to please give us feedback in any way that we can improve our work and make sure that we're serving our community to the best of our ability. For some housekeeping, we will be taking questions in the chat box, and then I will read those to Dr. Sarah Smucker-Barnwell. And we've scheduled it so that there'll be 2 to 3 times when we will slow down, take your questions, and then carry on with the presentation. So feel free to put those questions in the chat box and we'll make sure that Sarah gets those. You'll also be getting an email at the end of today's webinar that has a link to our survey. It's really a very short survey these days. I'll also put that link in the chat box, which is easy to click over to. In addition, we will be sending everybody a certificate of completion. You don't need to do anything. That'll come to you automatically. However, if you are joining in a group and there are several people in the room with you, please send us an email with the names of people and their email address at the northwest@attcnetwork.org, and we'll send individual certificates to the people that you identified. As I mentioned earlier, today's speaker is Dr. Sarah Smucker-Barnwell, who is a licensed clinical psychologist who provides evidence-based psychotherapy and consultation in the greater Seattle and East Side areas. Her research and publication interests focus on the ethics intersection of technology and evidence-based therapies. Sarah's a partner of the Seattle Psychology, and she's a former director of telehealth training and education for the VA Puget Sound healthcare system. And with that, I'd like to turn this over to Sarah, and thank you very much for being here tonight, and thank you very much to all of our participants.
Thanks so much, David, and thanks so much to Northwest ATTC for having me tonight. And thank you for coming to the webinar. Tonight, we are going to talk about client selection, intake, and assessment in telemental health. And this is, I may ask that I am given permission to drive from our moderators. This is the third in a series of learning series of installations. This is number 3 of 6. And tonight we're going to spend about 2 hours together doing some lecture and then answering some questions along as we go. So here are the other topics that are upcoming. You can register. I believe if you register for one, we register for them all. But if you needed to, if you're watching with a friend as someone did last week, please go to the Northwest ATTC website where you can register for future courses. Okay, I'm Sarah Smucker Barnwell. I'm a clinical psychologist licensed in Seattle, Washington. And as David mentioned, I've just had the great fortune of having this really wonderful and exciting career in telemental health. It has been really the passion of my professional life to think about how we can expand access to good care for our clients through using emerging technologies. I had the opportunity to contribute to several guidelines documents such as the American Psychological Association telepsychology guidelines, several iterations of the American Telemedicine Association best practice documents, and some other policy and regulatory guidance. I'm a prior CSATE fellow, which is the Center for Excellence in Substance Abuse Treatment and Education. So the intersection of thinking about how we serve SUD clients well in the telehealth milieu is one that's really, really something I'm very passionate about. And I will jokingly say I'm an unapologetic telehealth evangelist, meaning I really believe in this modality and its ability to help us to deliver the excellent care that you give your clients in new ways and really expand that access. Okay, so some learning objectives for the evening. We're going to speak about client selection. How do we determine who we should include in this telemental health practice, acknowledging that this has really changed over the last several months? How we thought about selecting our clients, or if we got to think about selecting our clients for telemental health, may be very different now than it was several months, depending on where we live, the rules of our jurisdiction, and our own personal decision about, how we want to conduct our practice. We're going to spend some time thinking about initial intakes and assessment in the telehealth milieu, inclusive of neuropsychological assessment, forensic assessment, and assessment of youth. And then we're going to talk a little bit about building your practice because we're in a new phase for many of us. Perhaps some of us really started to implement telemental health in the earlier days when COVID-19 first came here to the United States. And for many of us, it was quite a rush and quite a shock. And perhaps we work for an organization where this was the only option for delivering care. And now I think as many jurisdictions reopen, this becomes more of a question. Do I want to have telemental health continue to be in my practice? And if so, what does that look like? How can I build that practice in a way that feels appropriate and sustainable for me? So just a little bit of housekeeping. We're going to start off having some lecture. We'll stop, as David mentioned, several places to do some live Q&A. Please, as you think of them, go ahead and enter those questions into the chat box. We'll have some video demonstrations. And if you happen to not have your question answered tonight, or if you're like me and you think of your question after the class ends, please don't hesitate to send it in to nwattctelehealth@gmail.com. This is an email that I will be observing, and I'm happy to respond to questions that folks have. And if it's a question that I think enough people would also share, I often will try to put it at a section at the end of today's class, where a section we call That's a Good Question. Okay, and then of course we'll end again with live Q&A. So a disclaimer, anytime you give a presentation about technology, something goes south with the technology. It almost like it's sentient, and I've angered it by looking at it. I'm here really to offer my best practice recommendations based on my clinical work. I spent about a decade delivering care explicitly and only over video conferencing. I'm giving you my synopsis of the literature as I see it and my experience working in regulation. These are the personal best practices and guidance in an emerging area that I've cultivated in my career, but I always want to acknowledge this is no proxy for looking at your state and jurisdiction's regulations, consulting with your own legal counsel, consulting with your risk management, especially if this is offered through your malpractice coverage. And, I jokingly say, I'm not offering legal advice or clinical advice. I'm not a wealthy woman. So that is please don't sue me. It's my risk management statement. Okay. Thank you. Okay. Conflicts include, I do like folks to know that in my professional life, in addition to seeing clients, I do offer telehealth training. So I want to acknowledge there's potential conflict to be had there in that I promote telehealth. But again, the reason I do this is I really believe in this modality and its capacity to expand good care. Most of us who have been involved in telehealth over the years really got our start in themes of care expansion. Rural healthcare access is a not uncommon path to telehealth. and really other modalities wherein the primary concern was making sure that clients who wouldn't get care or wouldn't get the type of care that they needed could have access. And I have to say, it's been a tremendously rewarding way to utilize technology, and a great way to just give care to clients who otherwise you wouldn't have been able to treat. Okay, so some of the themes we'll talk about today as we are preparing your office for intakes, assessments, and building that practice after the fact. We're going to think through client selection. What are your inclusion and exclusion criteria going to include? Reviewing themes of intake assessments, assessment questions and formal assessment batteries, and termination. I've heard it said that we're thinking about termination from that first session onward. So how do we think about it in the telehealth milieu? Going to give some attention to special populations, such as those conducting neuropsychological evaluations, forensic evaluations, or those working with adolescent or youth. And then finally, talking a little bit about building your telemental health practice, how we might advertise that, how we might help train staff if you have support staff in your office, and the continued role of physical space. Do you really need a physical office? And if so, what might that look like? There's always a balance, I think, in these multi-session courses where we're trying to review many topics and do a deep dive on some. My hope is that folks will submit questions as they occur to ensure that you're giving of your time and make sure this time is valuable and helpful to you. I will mention that if there's a theme that we do a more cursory review of, the prior classes in this series will be available on demand through Northwest ATTC's website. And just as a show of hands, I'm curious who here has been here before. I'm wondering if you have been here before, please go ahead and, write in the chat box, yes to the question of, have you been here before? There's not a big change we're going to make tonight in response to that, but it's a census that David and I thought would help us understand continuity of who has been here previously and maybe who might be here for the first time, and will help us inform future content to make sure that we are aligning with the interests of folks who come. Okay, let's talk a little bit about definitions and examples. And again, this is abbreviated because I know some folks have been here multiple times, and I'll just try to keep it short and sweet. Okay, telemental health. TMH, you'll sometimes see it as abbreviated. Really the provision of any mental health service using telecommunication technologies. And telecommunication technologies is a vast and diverse group of technologies. So this includes the telephone, and this includes the fax machine, and email, and secure messaging, and text. Really any way we can communicate through technology falls under the rubric of telecommunication, and therefore in telemental health. And I will mention that mostly when people say telemental health, they are referring to video conferencing. Video conferencing and telephone more broadly, and mostly video conferencing. So, I will note that this category is broad, almost to the point of, I think, not offering us a very distinct meaning. But, anecdotally, when folks say a telemental health session, they're most typically talking about a video conferencing session. And again, I'll just reiterate, access. This is all about access. In our current health climate, making sure that we have mechanisms to protect your health, the public's health, and your client's health, I think is going to help sustain care access during a period of time where we're really looking down the barrel of a mental health care crisis in the country. So I'm grateful for you all being here, and I'm grateful for your interest in the modality. HIPAA, it's one we hear about a lot. Health Information Portability and Accountability Act. HIPAA consists of the privacy rule, making sure that we keep the information we learn private, as well as the security rule, making sure we keep it secure. I had a class a little bit earlier in the day where someone asked me, do I really have to be HIPAA compliant if I'm not using video conferencing, if I'm not using telemental health? And it's like one of those moments where you can really answer a question succinctly, and it was yes. The answer is yes. Regardless of whether we are conducting our care through telemental health, if you are regarded as a covered entity, you must comply with HIPAA, and most mental health practitioners are regarded as covered entities. PHI, or protected health information, and these days we call it about ePHI, electronic protected health information. Many of us are familiar with PHI in the context of client names or addresses or birthdays, and you would know that you wouldn't, tell your spouse your client's name or where they lived or, identifying information about them. What's interesting in the telehealth milieu is it really brings to the fore that there are pieces of electronic information that also fall under the rubric of PHI, inclusive of IP addresses, account numbers in your medical record, device numbers and serial numbers in some circumstances, depending on what type of equipment they're using. So I think it's interesting. And really, for me, it highlights the manner in which, and we'll talk about this in many places, and throughout every class of the series, we'll talk about this, our software, our hardware, all the information that touches, that video conferencing appointment, that telephone appointment, we want to treat it like protected health information. We want to password protect it. We want to lock it up when it's not in use. And we want to treat it with a certain degree of respect, that we would a paper document that had our client's information on it. Okay, business associates agreement. You'll often hear this called a BAA. Here's a nice picture of one. It's a contract between a HIPAA-covered entity and a HIPAA business associate that is used to protect personal health information, that PHI, in accordance with those HIPAA guidelines. So really, where this gets salient is when we're selecting technology products, for example, a video conferencing platform, or perhaps an electronic medical record. And those are two themes that we talked about at great length in our prior classes. For those folks who are looking to select a product, we want one that will give us a signed BAA. And basically that document says, they know that we're a covered entity by HIPAA, and they will behave as a covered entity as well. Oftentimes, a product will have a HIPAA compliant option, and they'll usually charge a little bit more money for it. Very typically, it is the same product with a few features disabled. However, it's the type of good risk management and documentation and just, coverage for you that helps you sleep a little better at night and know that you're investing in your telemental health product or practice in a way that makes sense and makes good use of good products. So get that BAA. It's a shorter way to say it. Okay. And I really just want to acknowledge, so much about the conversation of telemental health is different right now. And I really want to just hold the fact that many of us may come to this class tonight, not because we have a burning interest or desire in the modality. 6 months ago, telemental health was kind of obscure. And if folks would come to a lecture I did or a workshop I did, I would know it was just, maybe this was something they were interested in trying out. Now, however, because of the public health crisis ongoing, many of us are, endeavoring to implement social distancing. We may be living with stay-home orders, and this becomes a tool to navigate some of these mandates, perhaps to protect our health or the health of our clients. And it's just a really different conversation. And I no longer presume that this is something that folks have great enthusiasm in their hearts for. I hope, as a telehealth evangelist, I can maybe it's a little infectious and people will feel some fond feelings toward the modality, but I really just want to acknowledge this is a hard time to be adopting telehealth. And again, I really respect and admire my colleagues like yourself who are willing to invest the time in doing this thoughtfully and well. So thank you again for being here. Client selection. I think one of the questions I most often hear from prospective telemental health users is, well, what's the research on, outcomes? What do we know about telehealth versus in-person versus telephone and other, modalities? And generally speaking, and I'm happy to go into a deeper dive on this in the future if that's of interest, please put it in the text box if it is. Research suggests, by and large, equivalence of in-person interventions and many remote treatments. So mostly the most well-studied is video conferencing, though there's also a pretty compelling literature on telephone. And, there's diverse studies that look at the treatment of depression, anxiety, post-traumatic stress, anger management, psychotic spectrum disorders, and of course, suicidal ideation and suicidal behaviors. We have a lot of data that suggests that outcomes for these diagnoses are quite comparable in-person versus telehealth interventions. Now, I will note that these randomized clinical trials are newer, and oftentimes I think the piece that the critique would be that they lack is the longer term follow-up. So do the gains maintain the same for both modalities? That I feel like is less well studied. But by and large, the data we have is good. So to date, I am not aware of much data that has ever found, it to be an inferior modality or a way in which we're having diminished outcomes when it's done at an RCT level. And I will say there's a lot of data on client satisfaction. The client satisfaction data tends to be very good. Clients tend to like their telehealth. They tend to report pretty high feelings of rapport towards the provider. Now I'll share with you the bad data. The bad data is that providers struggle actually more than clients. And I always think that's an interesting finding, but it's pretty consistent that providers may have more to say about, not liking the modality as well. And to me, that makes a great deal of sense from the perspective of, we as providers, we're watching a lot of small things. We are doing behavioral observation. We're really paying attention to the moment, to the interaction. We're paying close attention. And I think we are having a more impoverished experience in the modality. There's just information that we do lose. So I will say the one piece of data that's less favorable is provider satisfaction can be lower through the modality. That being said, this is not a clinical specialty. It requires competence, and we require some training in figuring out what we're doing. We must observe the usual standards of care and observe our ethics codes relevant to our license. But at the end of the day, it is not as if this is some, inaccessible or really something you'd have to go to a postdoctoral fellowship to learn. Although I will say there are postdoctoral fellowships in telehealth, and I used to oversee one, and it's great. But at the end of the day, this is about bringing the good care that you've always delivered, to a new modality that we believe offers a comparable standard of care. So, back in the day, we were always asking, why are we delivering remote service versus in-person service? This is even written this way into the APA's telepsychology guidelines, asking, well, why is it that we would offer telehealth care? And I think previously the answers would have been things more like barriers to care access. So mobility challenges, health challenges, perhaps financial limitations, or just straight distance from care. And frankly, I would rather my client, meet with me via telehealth and have 3 extra hours in their day to spend doing activities they enjoy or things they need to do than, spend that time traveling to see me. But I think, again, the conversation has really shifted, and it is much more, a necessity in some areas, and for others, a tool that they are using to align with how they wish to manage their health or the health of their clients. I think, what's really interesting, and we talked about this last class, is as we consider returning to in-person care, it is recommended by the American Psychological Association and the American Insurance Trust that we consider capturing informed consent for return to in-person care, and in some ways inverting this question. So now, instead of asking why remote services, now I think we are being held a little bit more to answer, well, why are we doing this in person, when we could do it via telehealth, which I don't have a lot of comment beyond just saying I think it's an interesting, shift of tides. But again, this assessment will be evolving. I may initially think someone could be a great fit for telemental health. We get in there, we start to work together, and it's not. We always know this when we start with a new client. I may bring someone in for an intake assessment, and as I get to know them, I really understand that their concerns might be outside my scope of practice, or perhaps I know a colleague who I think is better suited to care for them. So too, I think even when we are doing telemental health with an existing client, that relationship may have gone swimmingly in person. But sometimes there are impediments to, that flow and that rapport that we encounter in the telemental health modality that just really make it much more difficult to serve that client that way. I don't say this to be a downer, again, known evangelist, but I want to acknowledge that this is going to be an ongoing assessment. And I really want to liberate us a little bit to say, I can treat this as not a one-time thing. If I say somebody's a good fit for telemental health and we get into it, and that is not the case, then, indeed, I'm allowed to back off that, and change my recommendation. Folks will often ask me, well, which clients should we see and shouldn't we see over telemental health? And I really, I perhaps frustratingly will turn it back to them and ask about their boundaries and their preferences. And the reason I do that is there are very few data-driven reasons to exclude any particular type of client. There's no research that says we shouldn't see this client or we shouldn't see that client. I want to acknowledge that there are going to be clients that we see that are going to be more challenging. So for example, it is always challenging to see a client in crisis or who really needs, a lot of support. Again, there's no data-driven reason not to see that client over telemental health. However, I think it's a very valid, boundary for us to decide how much do we feel comfortable delivering that type of care over telemental health. I think an analogy would be, well, back in the day, if someone had concerns about harm to self, we would actually send them to telehealth in between sessions. We would send them to hotlines, and have them receive support in this way. So, there's precedent for delivering care to even clients who are in great distress. But I think it's permissible for us to set boundaries and say, well, I don't know if that's something I really want in my practice. I'm learning this new modality of telehealth. As I said in previous classes, it's advisable for us to go with what was really our bread and butter, those early telemental health cases. So if I'm someone who treats, alcohol use disorder and comorbid anxiety disorders all day long, it might not be the greatest time to have my first case, trying out a therapy I've never tried before and trying out telemental health. I would make the recommendation that we try out one new thing at a time. So again, I would put it back to what type of clients do we typically see in our in-person practice and what are our boundaries around that? And really starting to think about how that translates as we learn the new modality of telemental health. And at the end of the day, it's in many ways a question of risk management. What am I comfortable doing? What do I feel is within my scope of practice? So thinking through what population do you serve? What services do you offer? And what do you want your practice to look like? I mean, I think that's a funny way to put it. And we're always sort of balancing, I think, ethics of service to our clients with sustainability and self-care. I once did have a practice that had, I think, 75% of my cases were receiving prolonged exposure therapy, which is a pretty intense therapy. And most of those clients, in addition to post-traumatic stress disorder, had comorbid SUD. And I think there was this day that I came to work and I thought, this is a lot. maybe I needed to transition a little bit and maybe not see every case in a day as a PE case. Maybe that's not the best strategy for my self-care because maybe that could lend itself to burning out. So again, as we're thinking about bringing telemental health in, thinking about who we're most comfortable serving, the services we feel the most confident in, and really what do we want our practice to look like, as we transition to having more telemental health in it. Okay, when we think, having said there's no, data-driven reason to exclude or include a current client, I do want to go through some of the characteristics that folks may think through in thinking through whether or not a specific client would be a good fit for telemental health. So, clients, telehealth has long been a modality that can assist with vision or hearing loss. I want to acknowledge that hearing loss obviously is the better fit in the case of video conferencing. The ability to turn up and down the volume, the ability to enlarge a screen, the ability to have a telephone call instead of a video conferencing call, and make sure that that's through headphones that have some sort of, adaptive listening device that is helpful to the client. All of these mechanisms, well, technically could be done, in an in-person session, I think really blend well in a telemental health modality. I recently saw a client who had profound hearing loss, and through the use of a software program that he used to sort of navigate the world, was integrated into the video conferencing program and actually offered us each subtitles to our video conferencing call. It was very slick. And flowed very nicely. And I think we could have done it. We had done it in my office previously where they would bring a mobile device and we would go back and forth from that mobile device. But there was something, I think, even a little more fluid about having it at the bottom of the screen, not unlike a movie with, subtitles. I think it lent itself to nice care. So thinking through vision and hearing, I think this does get a little tricky. I will mention I have a colleague who is blind and offers services to the blind and laments the fact that very often insurance will reimburse more for video conferencing than telephone. She sort of shakes her head because here she is, she herself is blind, her clients are often blind, and she's having to do video conferencing appointments. And some of her clients certainly have partial vision or some vision where it's advantageous, but some don't. And she's, sort of chuckling like, why are we doing this other than to be on the up and up with the insurance? So, it can be a bit frustrating, but I think all in all, these offer technologies that can help us really make care more accessible. Client preference for the modality, and sort of the practical adaptability of the services we offer are going to be really big, portions of what we do. Again, 6 months ago, if someone told me, well, the client doesn't want to do telehealth, that would have been the end of the conversation. There would be no further discussion around this. And in many ways, it still is. However, if you live in a jurisdictional area where you are, with stay home orders currently, or where, you're not regarded as an essential worker, mental health care is not regarded as essential, this gets more challenging. Telehealth may be their only viable option for the time being. And in those circumstances, we want to be thoughtful about how we can adapt the telehealth modality to be a better fit for them. At the end of the day, though, I think this is just a very new chapter, because previously, if the provider wanted to telehealth but the patient didn't, that would just sort of be the end of the discussion. But now, I'll share my own health history is such that I'm actually in one of these high risk categories. I really shouldn't be given in-person care right now. So for me, it is the case that I'm going to be delivering telehealth for some time. And again, 6 months ago, that just wouldn't have been in my conversation. If someone didn't want telehealth, they want to see me in person, of course they'd come see me in person. Now that's not an option in my practice. So again, these are things we want to think through when we're thinking about a client's appropriateness. When I say practical adaptability, I really refer to the work you do. I have a colleague who is very well trained in somatic experiencing and integrates some of this work with body work. And their practice is very hands-on, and really it's a struggle to do that remotely. So again, thinking through how adaptable is the service you're delivering that particular client to the milieu. Your client's health status, the health status of their loved ones, again, what the jurisdictional rules and requirements of where you live might be, and what other care access does this client have? If they live in an area that is not at all hit by coronavirus, but they're going to, come see you, would a local referral be better for them? And again, we're always thinking about themes like distance from care, medical impediments they might have to mobility or receiving care, or financial limitations. It's notable we should be thoughtful about clients' clinical characteristics. And again, there's no single diagnosis that I would ever say, oh, we don't see clients who carry that diagnosis over telemental health, but they are things we want to be thinking about. I will say in my practice, I think long and hard about the extent to which I want to serve clients who have some manner of clinical avoidance in their presentation, or who have delusions regarding technology, ideas of reference regarding technology, recording, observation, so forth. Those are clients I really think long and hard about. Again, that calculus has really changed. 6 months ago, again, I probably would have just recommended in-person care. If a client has, for example, agoraphobia, I want them going out and coming into my office and having that experience. That's part of the exposure therapy that I think is indicated for their diagnosis. So too, if I think that the modality would exacerbate delusions regarding technology or recording, I wouldn't see that as being constructive. Now, however, I think we're having to think this through a bit more. I did a consult with a colleague this week who saw a client who had a considerable number of delusions and ideas of reference about recording and technology. And this was really a challenge because they're in one of the most hard hit counties, in the entire United States. There really is very limited in-person care that they could be given outside of emergent psychiatric care. And so they really had to have a long conversation about whether or not this was the right time for care, and or were there accommodations that they could make that would help the client feel more safe. I think this was really challenging from the clinician side, as they did not want to participate in a delusion simultaneously. They want to prioritize their client's preferences. I usually think through a client's treatment history. And what I mean by this is oftentimes in telemental health, I have served folks who've never had a therapist previously. There's been some care access barrier. I think this will be interesting. This and the satisfaction data will be super interesting in this current context, because I think we're going to see a much greater diversity of folks having telemental health care. And I'm going to be curious what they think of it. That being said, if someone had 25 telemental health therapists in the last month, that's something I would think about, whether or not I thought they were appropriate for my telemental health practice. I'd want to know a little bit more about what was going on, and how this was relevant clinically for them. I'm thoughtful about that person's clinical stability. Again, I will see clients that have active suicidal ideation, intent, or plan, but it's the type of thing that I want to really think about in advance. I want to be thoughtful about their history with self-harm, their history with the need for hospitalization, and what that means in the current context of coronavirus. I want to be thoughtful about my bandwidth to help manage a crisis should it occur for them. And generally, I just want to make sure that, I'm delivering the best care that I can to them, and that I'm being really thoughtful about what I think they need in a clinician at this time. When treating clients with SUD, there may be additional reporting that are required. So perhaps urinalysis, breathalyzers, reporting to parole officers are all examples of reporting I've done in my career. Um, I think that this gets a little tricky in the context of telehealth. And one thing I'm always checking on is whether or not the reporting agency has some sort of plan for how to do this remotely and or will accept telemental health appointments to fulfill their requirements. Transportation concerns, this cuts both ways. I've certainly done telemental health with folks who just did not have transportation to reliably make it to care. I've also done telemental health with folks who've had DUI histories such that they've lost their license, or that they've really just driven intoxicated to the point that I don't feel ethically good about increasing their number of appointments across town. And so we're using telemental health to deliver their care. When thinking through medication-assisted treatment for opioids, it's notable that we can serve these clients via telehealth. In fact, there's a really robust empirical literature on doing so. The DHHS and Office of Civil Rights announcement that I will reiterate for anyone who's new, a couple months ago, Department of Health and Human Services came out and said, oh, you guys can go ahead and use non-public facing video conferencing products. So that's your Skypes, that's your FaceTimes, that's your Zooms. And they basically said, we want telemedicine to be available to everyone. So go ahead and use those products. And I want folks to know this does apply to medication-assisted treatment for opioids as well. There are some special legal considerations for controlled substances. Specifically, if you wanted to learn more about this, the Ryan Haight Online Pharmacy Act is one piece of federal legislation that does get intersectional with telemedicine. So again, Ryan Haight Online Pharmacy. And this is a piece of legislation really, I think, trying to target online pharmacies, so for example, just buying pills like on Silk Road or something like that and ordering them and having them sent to your home. I think unfortunately telemedicine kind of got swept up in it. So there are some additional considerations when offering medication assisted treatment for opioids, if indeed it will involve the prescription of controlled substances. But I do want to just mention telemental health is a totally appropriate way to serve these clients, and that democratization, that ability to use Skype, FaceTime, these other products does still apply. I try to think through, does my client have a care environment that is appropriate? So as I mentioned in prior classes, I have seen folks in cars, in closets, in bathtubs, in wacky places over the last few weeks. But before I take on a client, I do double check, make sure that they do have a space that we can meet on a regular basis. I try to think through, will their insurance cover this? Now, I will mention again, we're in this sort of, unprecedented period of regulatory change wherein insurance companies are offering coverage for telemental health in unprecedented ways. So now more than ever, insurance is covering telehealth. And indeed, in many states, such as my state in Washington, they've passed executive orders that require parity, reimbursing at the same level as in-person care. So, if you're hoping your client will be covered by insurance, it's probably the best time in history, in terms of rolling the dice on that. I want to be thoughtful about the client's ability to have privacy. Some folks, this is an element of stigma. Perhaps they live in a very small town and, couldn't receive mental health care otherwise without knowing, everybody in the office. So telemental health care may offer a valid option. But again, first and foremost, we're really talking about the impacts of COVID-19 in driving, why clients would need this. But as we get back into in-person care, I want to just make sure we're inclusive in thinking of all the considerations that can drive us toward a telemental health care modality. Think about our clients' technical capabilities. What is our bandwidth to teach a client? Do we have the wherewithal to really sit them down and explain how the technology works and walk them through the steps? There's really interesting research to me that says, nothing, not a client's age or gender or education or even, prior experience is as good as a really good explanation. My colleague Megan Juretic did a really interesting study talking about utilization of telemedicine and found that, when people took the time to really explain how a device worked, that seemed to be the best predictor of good outcomes, which is pretty darn intuitive. And yet, I think sometimes we treat it as though, one group of people will learn it more easily or they will, not be able to pick it up. And I think that's just not true. I think that if we spend the time and we're patient, and walk folks through it, really most folks can use these technologies. They're pretty user friendly. But again, we have to be thoughtful about what type of support do you have to do that? Do you have support staff to assist you? Is this something that you could manage to do on your own? And, where are you with that? Does the client does the client possess the necessary technical resources? So they're pretty minimal, all things considered, but we don't want to assume, they need to have either a mobile device or a computer. They need to have the internet. The hardware or software likely you would provide. Most hardwares and softwares, the software you would provide, not the hardware. You're not going to buy them a computer. But most video conferencing programs, telemedicine programs these days offer web-based links. So it does not, back in the day, clients used to have to download complicated software, and mostly that's not the case these days. And really a mobile device or a phone, will get the job done. I think data on smartphone utilization in the United States puts it over 75% at this time. So I'm always surprised by that number. Lots and lots of people have smartphones currently. So I think that is heartening to me in terms of access to telemental health, because that really is the minimum, that they will need to participate. And as we go through these criteria, I'm certainly not trying to suggest that there's a perfect client and everyone else should be excluded. Far from it. But it's my hope that in thinking through some of these characteristics, we can, make good choices that help us think through what our boundaries are, think through, what do I do well, what's inside my scope, what feels outside, and what clients am I going to be just the most successful with. I like to think through emergency probability with a client. That relates back to clinical stability, any client receiving interactive telehealth care will have an emergency plan. That's just good care. That will be part of your informed consent for telemental health. You want to think through what you're going to do in case of medical or psychiatric emergency. Most often, this is referring the client to a local hospital or having a wellness check conducted or sending paramedics to their home. And, it's notable not every quote unquote emergency is going to meet that threshold. You have technical disruption, and maybe the client's just mad at you and doesn't want to talk to you. I'm not going to send the police to their house for that. It might be a little bit gratifying, but it would be wrong. I think in these cases, we want to think through, what am I going to do? Is there someone else in the home that could help? If there was a technical issue, is there someone else, who I could touch base with if I had concerns? Not that they were unsafe, but just to check in on how they're doing. And in that case, can I capture a release of information for that person? And always I'm thinking about where will that patient discharge if care is no longer appropriate, if they need a higher level of care, where could I send them? Remember your clinical considerations. And he says, I don't care what your chat group says. I think you're becoming overly dependent on technological gadgetry. Haha. I have offered this. I suspect the font is very small. And so really, I just wanted you to have it because you will have access to the slides afterward. This is an appropriateness assessment that I created. It's just a little, I think it's 14 items going through, the clinical assessment. These are the items I think through, technically and in terms of the client's clinical presentation in thinking through whether or not it's a good fit for my practice. This is a starting place, by no means an ending place, but I wanted you guys to have a copy, that you can use and adapt as you see fit. So, the takeaway. Convenience is neither a solely determining nor deterring factor. We really want to try to align with clients' preferences always, and we want to make care as convenient and accessible as possible. However, we are also allowed to set boundaries, to acknowledge that not every client might be appropriate for our telemental health practice. And there's no codified exclusion criteria. There's no research-driven reason that we would exclude a client from telemental health. We want to know our jurisdictional rules, particularly regarding COVID-19. We want to make decisions using research and risk management. And as with your in-person practice, you don't have to deliver care that you feel is outside your scope or that you just don't want to deliver. I think it's always a balance. Most of the mental health practitioners I know are really ethical, thoughtful people who are driven by the desire to help. That's a wonderful thing about our community. And, I guess I want to communicate that we have the right to kind of figure out what our boundaries are and stick to them. Okay, here's a vignette. Dr. Evil. Today we're having superhero villains as our doctors for vignettes. Okay, so Dr. Evil, she has a client who has sought services for alcohol use disorder. The client is actively using currently and has comorbid panic disorder with agoraphobia. This is a client who is avoiding social circumstances as well, though does not meet criteria for a social phobia or social anxiety disorder. The client reports moderate suicidal ideation without active intent or plan, and some history of self-harm, not suicide attempt, but of cutting, scratching, burning. Okay, so what would Dr. Evil need to be thinking through? Dr. Evil would need to think through the accessibility of other treatment options. How is the client's health? Is telehealth the only way they should be receiving care? What is their willingness for in-person care versus telehealth? Is there a referral available where they are? Is this even an option? I would want to be thinking through with Dr. Evil the role of exposure. Is the client willing to pursue safe exposure? So if I determined that I was going to treat this client and help treat their panic and agoraphobia, would I be participating in that avoidance behavior if they were, I'm assuming they're demonstrating some, they have agoraphobia. Would the client be willing, if we did do our care through telemental health, would they be willing to seek out exposure outside of the therapy session? Is that something that they would feel comfortable partnering with me in doing? And how comfortable would Dr. Evil be with remote emergency management? Is this something she's ever done before? Is it something she's willing to learn about? Okay, we've hit the first of our several pauses, and David, I guess I'll turn it over to you. If you've had some questions, I'd love to take a few moments and answer those.
Hi, Sarah. And a few more questions might come in, but we only have one so far. So
Okay.
I'll ask this one from Tom. And Tom says, I have a number of hearing impaired and language impaired clients. How is the ADA responding to telemental health services?
I think that's a great question, and I will go do my homework. I cannot tell you specific to ADA. I can sort of speak anecdotally, and I hope that's helpful. Among the providers I have consulted with who deliver ADA compliant services, a few things. One, some frustration because many of the technology products that are most popular in video conferencing are not as accessible. And some of the products that are most accessible are not as popular. And so I think that there has been a lag in terms of telemental health really offering sound accessibility in their technologies. I think we're going to see this explosion in telemental health technologies because of the explosion in utilization. I used to jokingly say we can't have nice things, and I think that's changing. But I think the reality is that the tech is, I think, not as accessible as it could be. That being said, certainly I've had a lot of folks tell me their hacks, the ways in which they are utilizing existing technologies. So for example, my client who has an assistive transliteration program that is helping to create subtitles, for all his video calls. It's a great technology, and thankfully it happens to couple with Zoom. And so it's something that he's able to use to have video calls. But I wish I had a better answer. I think it's not where it needs to be. I think there are some things that are inherent to the modality, like for example, in the case of hearing loss, you can turn the volume up. I'm somebody who's soft-spoken, and I think some of my clients like the opportunity to turn up my volume a little bit. Maybe some people would like to turn me down. I don't know. I think that there is some things inherent to the technologies, but I think they have a long way to go to be truly accessible.
Thank you, Sarah. Renee commented on your assessment. Notice you had a copy. Do you know where there are other templates that can be found, like for licensed clinical social workers?
Sure, it's a great question. So I would say feel free to use mine. You'll have access to the slides. It was a teeny little picture, and I can't imagine anybody saw it. But as you have access to the slides, you'll be able to see it there. Other great templates that I really like include those available through the American Insurance Trust. They have some really nice, thoughtful risk assessment documents. I will also mention my colleague Peter Shore published a document called the ASH 25, ASH 25. And gosh, I couldn't for a dollar tell you what the acronym stands for, but this is an assessment of safety for telemental health appointments delivered in the home. So he has actually published this. I think there's been some psychometric evaluation of the measure. And so I would recommend the ASH 25. I would look at the American Insurance Trust. And of course, you're welcome to my template.
Okay. Another question, a person by the name of Jen works in community mental health and wanted to know, she was unclear if Medicaid covers telemental health sessions when they're done by phone.
So, that's a really good question. It's on the tip of my tongue. Medicaid or Medicare?
She said Medicaid.
Medicaid. Often Medicaid will follow the guidance of Medicare. So I'm kind of punting on this because I know what Medicare's answer is. Medicare very recently has increased reimbursement for telephone appointments, and that's new. I don't know that they are offering parity. Typically speaking, I would say always contact the specific insurer, the specific program. And that's such a lame answer, but it's also pretty darn true. I think you can check the Center for Medicare cms.gov website and see if they have any new announcements on this, because literally this was just changing in the past week, so forgive me. Historically, no. Historically, they have treated it as a 98968, 98969, which is like a telephone consultation with a non-physician for most mental health care appointments, and it was reimbursed at a much lower rate, and most insurance followed that suit. My understanding is that with everything going on, there's been a strong push federally, to see higher reimbursement for telephone. So I would double check. I believe it's higher. I don't know if it's exactly the same as video conferencing appointments, and that would be the question. And I will happily research that and bring it to the next class.
Thank you, Sarah. Here's a kind of a clinical question from Brian. Let's
Sure.
say you have a client who meets all your selection criteria, but after seeing them for a series of sessions, there doesn't seem to be much clinical benefit. How do you differentiate the lack of therapeutic response due to the telehealth medium versus the therapy?
That's a great question. I mean, and I don't know that you can, to be honest. I would say that certainly I would lean into some questions for the client as to what their experience is. I would think about my experience of the client. Do I feel rapport? Do I feel connection? Do I feel that they are, motivated? Are they engaged in care? I think it is almost impossible to totally dissect that. At the end of the day, though, I don't want to say it doesn't matter. Of course it matters. But if I feel like I'm not giving good care to that client, my first steps are always going to be the same, whether it's in person or telehealth. First, I'm going to really try to collaborate with them and think about how we can improve it. And if we just don't feel like we're making the progress we need to, I would be inclined to refer. It gets a little trickier, though, I think, in telehealth referrals. A, you have to know where to refer them, and which of your colleagues are offering telehealth referrals. But B, they may encounter the exact same problem. So I think that I am a little more reluctant to refer in telehealth circumstances only when I think it's the telehealth, because it's, I don't know that I think it's going to be better for them. Although I don't want to discount the fact that they may just have a different rapport with another person over telehealth. We have different levels of expressiveness in our face. We have different levels in, our voice, and there may be something that resonates more, for that client with another practitioner than it does with me.
Okay, thank you, Sarah. Question from Peg. We are a multidisciplinary agency looking at delivery of services to clients seeking legal immigration services. Are there other factors to consider other than what has been outlined for telehealth services?
So I'm sorry, the question was specifically for...
They're offering clients seeking legal immigration services during some of their telehealth talks with them. Are there any other considerations that you know about?
There are. If it's okay, I'm going to pause because we do have a section on like forensics and thinking through when something has legal implications. And if it's okay, we'll speak to that a little bit later in the slides. And I hope it answers your question adequately.
Okay. I got some more questions. It's taken me a second to catch up with folks, but here we go. Clients do not want to do video session. I'm curious if you have an idea why clients and community mental health might be opposed to a video session.
Sure. I mean, I think it's a really personal choice, and I don't sit in judgment of folks who don't want it. And actually, I have some slides on this later. There is this question of when someone declines video care that I want to, on one hand, absolutely respect their boundaries. They have every right to determine how they receive their care. And if it's just not for them, that's fine. Simultaneously, I want to know things like, are they mandated to have care? Is this a court mandated case? Is this something where, this isn't really a choice? I want to think through, to what extent do I think this is clinically relevant? To what extent do I think this is avoidance? And that's a very tricky line, because I think it's not really for me to say that someone has to like the modality that I work in. Simultaneously, I do get a little suspicious sometimes when folks maybe have been avoidant of care in many other circumstances, and this is a known pattern. So again, that's where knowing their treatment history kind of gets valuable. But it's a hard question to answer. And I think at the end of the day, of course we have to respect people's boundaries. I think people don't believe that they could have the same type of rapport that they do in person, and maybe they can't. But I will say overarchingly, there was a time for 10 years where I only saw clients over video, and I did not feel impoverished in terms of my connection to them. And that was me and that was them, and who knows if it goes the same for anybody else. But, I think it's one of those things that I won't even just say you have to try. You have to try a couple of times, I think, to really have a fully formed opinion, because it is very experiential. And at the end of the day, it's one of those things that we can hypothesize. I can hypothesize that I don't like riding a bike, but until I get on the bike, I really won't know.
Thank you, Sarah. Another question from Stan said, what would be a suggested pay portal for providing education or addiction treatment?
A suggested, I'm sorry, what, pay portal?
Pay portal, like for money.
In terms of receiving payments?
I think so.
Sure. Well, there's payment integration in many electronic medical records, and I think that's a great option. It's easy, so I have an electronic medical record. It has a way that clients can pay their bills. It has an ability to send super bills directly to the client or to bill insurance. It also integrates nicely with QuickBooks, which is what I use to do my accounting. That being said, HIPAA allows us to use really any payment product that we care to use. There's no prohibitions. I will say I don't love some of the ones that are public facing. So for example, there are some settings in Venmo where you can tell everybody what you just paid someone for, and I don't like that for payments. Not to say you can't use Venmo, but I would disable that public facing comment function. I don't really need social media on my payments, but really Chase Pay, Apple Pay, Venmo is appropriate, PayPal is appropriate. They're the ones that are integrated into our, sending a check's appropriate.
Okay, thank you. Here's a question. It says, I'm not sure that I read that we are able to see clients on FaceTime and even to bill for it.
Yes, that was the announcement from the Office of Civil Rights. So, and if you go to on-demand, sort of the prior classes I've done, I will opine at greater length than anyone wants to hear. I still don't do it. I don't think we should do it. I mean, yes, there was this federal announcement that said we can, and in a pinch, I guess if you gotta, go for it. But that being said, in my opinion, my board complaints aren't going to come from the federal level. My board complaints are going to come from my state regulatory board, and my state regulatory board tells me to use a product for healthcare. So I don't think we're in this really. I have a hard time imagining someone really coming for me and being super punitive, because I was just trying to do best by the client in this current environment. That being said, there's no guarantee, and so in my mind's eye, I use the products designed for healthcare, because why wouldn't I? To me, they're very comparably easy. There are free ones that are good, so yeah.
Okay.
It's to each their own, but I would use the healthcare products.
So Sarah, we got quite a few bit more messages, the questions that are rolling in. So you can tell me when you want to pause and continue to go forward. In the meantime, tell me.
I might suggest we pause. So we're about a third of the way of our slides, and we have an hour left. So I might, I will not dilly-dally.
Okay, so I'll gather these up and we can see what happens next. Okay.
Good. And of course, we'll have 2 more times where we're doing Q&A. Okay, so let's talk about intakes, assessment, and termination. Intakes. So again, these are themes I've talked about in prior classes. I'm going to try to move quickly, but just in case this is your first time here, we want to think about who we're going to see for that intake, the inclusion and exclusion criteria, what services we're delivering, what video conferencing platform or telephone platform we're going to use to see the client. We're going to schedule them typically by phone, but many people might use a secure email, or perhaps your electronic medical record has some ability to onboard clients and schedule them through some sort of automation. We want to know what the rules of our jurisdictions are, specifically as it relates to intakes. Some jurisdictions do have the requirement for in-person intakes. I've seen a relaxation of that in the context of COVID-19, but it's worth double checking. We want to think about how we're going to collect our payment. Are we going to bill insurance? And if so, making sure that the client's insurance covers telehealth. Again, and I've said this in prior classes, ASPPB, and David, if you wouldn't mind putting it in the chat box, ASPPB's website has a great research page for COVID-19 resources and reviews state by state some of the executive orders that have come out regarding the requirements of insurance to cover telehealth. And it's a nice resource, a nice succinct place to look. We want to think about who's going to pay for a session in which technology disruption occurs, if we're going to assess any surcharges associated with telehealth. And some places have historically charged an extra $20 for a telehealth appointment. That feels, I don't do it right now. I feel like that feels like a bit much, but sometimes it does incur additional costs and you may want to recoup them in this way. And again, how are you going to collect that fee? We want to think about your space, that austere background, making sure you have adequate lighting in a room you cannot be overheard. Again, I always encourage the use of headphones because I think this helps ensure your client's voice will not be overheard. And these themes are even more pronounced in the home office where we still have to protect that PHI and that EPHI, but our privacy can be somewhat impaired, as we're sharing our space, particularly as we're quarantining and maybe have kids in homeschool and partners working from home and the dog, won't leave us alone, all the things. And if you have an Alexa or an Echo in the room, unplug her, she's listening. Again, going quickly because these are themes we've talked about in prior classes, we want to think through our documentation that informed consent specific for telehealth, even if this is an existing client and I already have one that is on file for regular services, I want to have a telehealth informed consent. And that's going to detail things like my emergency plan. If something goes amiss, how am I going to handle that remotely? It's going to talk about technology disruptions and of course the risks and benefits of the telehealth modality. I want to think about how I'm going to collect those questionnaires for my client in advance of the intake. And again, any release of information I might want or any payment information I want to capture from them. Again, these can be simple documents. This is a lot I've listed right here. It doesn't need to be something that is just overwhelming. Again, I would point people to the American Insurance Trust as a place that has very nice online templates for all of these. American Psychological Association also has nice templates. So, there are places that we don't need to reinvent the wheel. We can download existing templates. Many of our electronic medical records may also populate automatic templates. And if this is just not happening, if you're just saying, no way, I can get all this documentation before the intake, some risk managers will say that verbal consent, reviewing all this information verbally and documenting that in your chart, meets a minimum standard, but that we should still go for those signed documents. And when I say signed, I mean the physical signature or capturing electronic signature through perhaps a software that your electronic medical records supports, or of course there are programs like DocuSign and others that capture digital signatures. Again, some jurisdictions have wacky rules where they want a physical with a pen signature, so you'll have to check your jurisdiction regarding what the rules are. By and large, though, most places do seem to allow digital signatures. Want to think through how we're going to exchange documents after that intake. Mail is great. It's low tech, gets it done. A fax, downloading information from your website, secure email programs or file transfer programs. And again, many of us may have an electronic medical record that offers a solution for this already. When we have our first intake meeting, we want to be communicating expectations to the client. We want to talk about the mechanics of that video call. I like to embed reminders regarding, them being in a quiet space that cannot be overheard by themselves. I actually embed that in the reminder for their appointment. So not only do we talk about it during that initial conversation when we're establishing the appointment, but they'll receive a reminder, right before the appointment. I like to think about what my boundaries are going to be, helping them think through what their boundaries are going to be. So again, that they're seated somewhere ready for an appointment, ready for an interaction with a medical professional. I could tell you some stories. I don't explicitly tell people to wear pants, things like that, but maybe I should, but helping folks understand this is a medical appointment. We want to treat it as such. Helping them think through how we're going to handle interruptions and what to do if they need some technical help. For clients that use the modality, I do recommend a 5-minute sort of check-in call. I have a training video on this in one of the prior classes, but just a little run through of the technology so that when you first meet for your intake, you can really get down to the clinical business first and foremost. As we begin the intake, we want to confirm that the client can hear us and can see us. We want to ensure that we're in the middle of our window and they're in the middle of their window on a video conferencing call or over telephone. We want to make sure that the audio is clear. We want to confirm that the client is in the location that they indicated in their emergency plan. And we want to make sure there's no one in the room. Boom mic isn't going to come down out of the frame. They're not recording it, that they're alone, etc. I always encourage my clients to silence any devices they may have in the room, to close any other windows on their computer, and to really just mitigate and minimize any other notifications that might take away from the concentration on our appointment. When I'm beginning that intake, I am reviewing those risks and benefits. I'm reviewing that informed consent document. So I'm also reviewing that emergency plan that I came up with the client. And I'm sort of trying to answer any remaining non-clinical questions. If they had any questions about the mechanics of how they got to this call or how we're going to do it in the future, I like to pause and explicitly ask, before I start asking you, all of the other questions about your life, anything just nuts and bolts housekeeping, and try to make sure that we have some space for that in our intake. When I'm conducting, a session, I'm seeing a client for the first time, an intake over telemental health, and over video conferencing explicitly, or telephone really, I like to collect a great deal of advanced information. So I really go heavy on the questionnaires. And I do this because it's hard to establish rapport over telehealth. And I want to come to that appointment having done my homework. I want to read what they wrote to me. I want to know what's going on, from to the extent they feel comfortable sharing it, with me in advance. I think it helps to set the foundation and really set the tenor for emotional connectedness in the session. And, of course, you're going to be engaging with your usual skills, all those usual clinical skills you have to help build rapport and really connect to a client when you're first meeting them. I find that it really helps to ask lots of questions. I just cannot assume some of the things that I might assume in in-person care. Talk about what I mean there. I do a structured clinical interview often. So, I'm going slower. The pace may differ. I slow things down. I'm asking lots of questions. And I actually use the SCID-5. I like to use some of the subsections of it. Any structured clinical interview is great. For me, it just reminds me to ask lots and lots and lots of questions because, again, I might observe psychomotor agitation. I might see their foot tapping or their fingers, tapping. If they were sitting in my office, I'm not going to see that over telehealth. So perhaps if I, lean into a sort of structured intake, that's going to remind me to ask about, do you at times, find yourself tapping your fingers, tapping your feet? I think that's going to help me remember to ask the questions and not assume that just because I can't see it, it's not happening. So again, when we're thinking about getting those assessment measures, and I'm really talking about assessment for therapy. So I'm talking about, substance use history. I'm talking about a PHQ, or I'm talking about, some sort of mood assessment. I'm not talking about the formal assessment cases, which we'll talk about in a little bit. I want to collect these in advance. Again, I like to verbally review them with the client, and sometimes I'll use screen sharing in my video conferencing to help them see a measure if they haven't completed it already. I do want to acknowledge again, this is very different because in a formal assessment, I wouldn't do this because I don't necessarily have appropriate norms. I think that there will be impacts. So if I ask you to tell me verbally the answers to a PHQ-9, this measure that's talking about your general mental health, if I ask you to do that, I have to think it impacts your responses relative to when I just have you fill it out on paper. Now, if I'm just getting to know you and I'm doing this not for a research study and not for a forensic case and not for a neuropsychological evaluation, but just to know how you're doing today, I still think it's a very valid measure and something that we should be, examining, but excuse me, a very helpful measure. It may not be a valid measure. It may not have demonstrated validity through the use of norms. So it's that type of thing where I think these are good measures and clinically helpful, especially in establishing rapport on initial intake, but I wouldn't necessarily bet the bank on them in the same way that I would for a formal assessment, which we'll talk about in a little bit. Behavioral observations. This is just, I think, one of the hardest areas. We really do lose so much. So eye contact and facial expression, it just may not offer the same information. Eye contact is inherently disrupted because where our camera is in our computer differs from where our client sits on the screen. So we always appear to look slightly downward. If my client was sitting in my office looking away, and I was having an in-person appointment, I would wonder some things. I would wonder if they were uncomfortable or perhaps there was something they didn't like about our interaction that was going on. I'd have a lot of questions. Now I'm wondering all those questions, but in addition, I'm wondering, are they distracted? Is there someone else in the room now? What's going on? And of course, themes like body posture and movements, gait, psychomotor agitation, alcohol on breath, other themes that would be indicia of what's going on with the client, you're just not going to get them in the video conferencing modalities or the telephone modalities. How loud someone is or how soft someone is can inherently be changed somewhat by the technology. So if someone was in my office and speaking so softly, again, I would wonder what's going on. I would ask questions about that. However, if I can't hear them that well in a video conferencing or telephone call, I don't make the same assumptions. Olfactory data, what can I smell with my nose? That's information that will be lost. And I'm talking about all the losses, but I do want to acknowledge there are things we gain as well. I'm seeing inside of clients' homes. I think this is especially helpful. I've said it before, I'll say it again, for clients who have hoarding concerns and discarding is going to be part of their care. I get to just have a better sense of what goes on in their lives. So it's not all without any upside, but I do think we lose a great deal in the modality. Okay, if you've been to my classes previously, you have met my long-suffering spouse who does videos with me. So here is a little bit of a video, talking about some of these themes because it's easier to talk about it. Hi, Jason.
Hi, Dr. Smucker.
How are you today?
I'm doing okay.
Great. Well, thanks for being here. I wanted to check in creating our agenda today, which we do at the beginning of every appointment. We had some homework this week. We were going to have you watch some videos of insects, and we were going to watch those repeatedly, and you were going to log your subjective units of distress scale, your SUDS scores, as you continued watching those. And I wanted to check in on how that was going.
It's going okay.
Okay. Did you have a chance to watch the videos I sent over the portal?
Yeah. I watched the videos. Yep.
Great. How many times did you get to it?
I think I watched them twice. Yep, twice.
Okay.
Yep.
Okay. And any change in those SUD scores as you went along?
Yeah. They got better. They got better. Yep.
Okay. Jason, I'm noticing something today. I'm noticing you're looking down a fair bit and, a little more constricted in your body posture. And I want you to know that's fine. We can be however we are together. I also want to acknowledge that's different from some of the ways in which we've interacted in the past. And if you were in my office, I have a strong suspicion, I would just have a better sense perhaps of how you're feeling today or what was going on. One of the challenges of meeting this way is that can't always tell. And so at the risk of making it super awkward, I just want to pause here and check in. How are you today? How are you feeling? I just kind of see you looking down and, I'm wondering what you're thinking and feeling in this moment. What's going on?
Yeah, there's just some crazy stuff going on at work. And yeah, I'm sorry. It's just being really distracting. And you're right. I don't think that I'm fully present. But yeah, it's got me pretty stressed out.
It's really hard to be present. I mean, I know this space is also your office for work. So I'm guessing you have all the reminders and all the interruptions and all those, things from work that, can be really stressful.
Yes.
Yes. So Jason, I guess, I want to offer, if you need to take a moment, if you think that it can fit appropriately within the timeline we have today, if you need to take a moment to respond to something, I'm happy to pause and allow you to do so. And then I would ask if you feel able to continue today for us to really come back together and try to resolve things to a point where you can really be present and we can do some of this work in the spirit of helping you along with your goals. Does that feel okay?
I think that'd be great. If really just 30 seconds to respond to this, I think my mind will be cleared and I'll be ready to be present and focused and engaged, and I won't have to keep coming back in a distracted way.
Okay. All right, Jason, why don't we pause for 30 seconds and then we're going to resume our session. And I might ask you to silence those devices and close those tabs. And, if you feel you can do that, to really, really keep us present here together today.
Can do.
All right. Thanks, Jason. Now, I know lots of colleagues who would have said I was way too soft in that moment. I do have colleagues who would say, that is treatment interfering behavior. They would treat it differently. They would not allow a client, some moments to finish what they're doing. I think that's valid. I think, maybe I'm a softie, probably. But, again, the behavioral observations that if I saw this person in my office, they were looking down, they were looking away, they were sighing, I would make one set of assumptions. In a telehealth modality, I just don't know, and so I will more often just stop, ask questions and honestly make it a bit weird. Okay, so let's say I've done my intake and it's now time to conclude. And perhaps I believe there is a fit, and I'm thinking about, what sort of clinical engagement I wish to have with them, how to meet their needs. Sometimes, one session is not adequate. It may take multiple sessions. So this could be at the conclusion of session 1 or session 2, 3, however many sessions you need to complete that intake. We want to discuss future homework and how we're going to be transferring information back and forth to one another. Again, secure email, integration into electronic medical records, fax, and the mail, are all really valid ways to do it. We can also use screen sharing. We can have folks take screenshots and pictures of, information that we share over our video conferencing calls. There are many valid ways to do this. We make all our usual concluding statements at the end of that intake. Maybe we're thinking about the number of sessions we would see a client and a tentative treatment plan, scheduling the next appointment, or inviting the clients to schedule online. I'll say I like to schedule them then and there. When you send folks off to schedule online, they tend to see them a few weeks later. The momentum may not hold. Review options or possible referral out if you don't think it's a good fit. And again, you've thought in advance about where those referrals will go. And of course, answer the client's questions if they occur. I want to think a little bit about formal assessments. So not just that measure of, how are you feeling today, but when there is a specific question that we're seeking to answer. I think remote assessment in telehealth modality it's complicated. This is a challenging time. The measures themselves may not have the availability of norms, in a telehealth modality. And there is this question of how valid, is that test going to be? I saw a great webinar the other day through American Insurance Trust that talked about the observation of the MMPI. So, technically when someone does a Minnesota multiphasic personality inventory or an MMPI, they just sit there and you just watch them. You really just sit there and watch them fill out hundreds of little Scantron bubbles, and I guess the point in the webinar was we can do this remotely. We can sit there and watch them, but I think it gets a little bit tricky. First of all, is the licensing on the product, is it allowing remote administration? So if it's just observing and sitting there, I think it's a little simpler. If there's some sort of interaction that needs to be happening with the test, some sort of interaction that, you're asking someone to do something back and forth, on the test, draw something, sing a song, count backwards and forwards. I think it gets a little trickier, particularly as it relates to norms, but also, are we permitted to use the test in this way? This is a great area for consultation, of course, but I want to acknowledge this is an emerging area and we may not have the answers. So I think, again, there's going to be some impacts to the modality, particularly if we're having people read and give us the responses. I just think there is a reporter effect that's going to happen wherein it's one thing to write down how you're feeling. It's another to, stand there and tell somebody. I think it will inherently, the process will impact the outcomes. And I think there's potential for secondary gain issues. So, we don't know what's going on outside the camera. And, there's a really notable case of, it was a bug in the ear situation where a parent desperately wanted a child to do well on an admissions test. Well, there's been lots of prominent issues around this, but in this specific case, they basically were feeding the answers to the child through a bug in the ear, through an audio recording device that was giving them the answers to the test. This is a lot more easily accomplished in telehealth modality. You just have to sit outside the screen and mute the audio, and this could be more of a collaboration than it was intended to be. So we just want to think these things through. I think now there is this incredible rush for the companies that make these measures to bring these tests online. We're having more observations through psychometricians. So, maybe someone is observing with the client at the client site, but the provider who is doing the assessment and the analysis is, at the distant site. But again, I think until we really have measures that are built for online administration, we are at something of a disadvantage. So I think the things that I'm considering, when thinking through assessments is the referring question still the same? So if I was brought in to do an assessment for a child for, how they're getting along in their classroom, well, now their classroom's via Zoom, potentially, is the issue still the same? Is the question still the same? Does the question still exist in some ways? What is the time sensitivity of the question? Can it be delayed or adapted? So again, if I was doing an educational assessment for a young person, and I wanted them, I would want to think through, do they need this right now to make choices for the coming year? Maybe they need a treatment program that has an educational component, or is this something that is put off, for 6 months until things settle down and really doesn't need to be done this moment? Can the test be adapted? I think it's a lot more easy to adapt a test that is a self-report measure versus something where we're having somebody build blocks or hand things back and forth to us. And of course, are norms available? Think about the licensing of the tests. I know many people are abbreviating those batteries and or delaying, if they're doing a formal assessment and they really just need to be sure they're adhering to the correct measures and using the measures as intended. I think this gets really salient in forensic populations. So, some of the questions I would have is, are courts open in your jurisdiction? So again, this gets to, does this, need to be adapted? Can it be delayed? I think this gets really challenging if someone is delivering assessment for a legal context over telemedicine. I think it tends to get ripped apart by opposing counsel. So, if you're using a test sort of off how it is recommended that we use it, and there's not established norms, it makes the assessment very vulnerable to, an attorney going through and saying, no, no, no. Again, there is this issue of secondary gain, I think quite salient in forensic evaluations that we need to be really thoughtful of. And many of us may have done these assessments going into the jail and working with our clients there. And oftentimes we're just not permitted right now. So are we able to access the clients, and if the answer is no, but the courts are open and it just needs to happen, then I think we do our best. But it's always this negotiation of risk and benefit and deciding, what is in the client's best interest? Is it delaying? Is it abbreviating the battery? Or is it going for it and just understanding we're going to have to make accommodations? For young folks, I know a lot of young people are talking about Zoom fatigue. And again, we want to think through, what is the relevance of the referring questions, like for an IEP or something like that? Again, many people who work with youth are reporting that they're having better success with abbreviated sessions. And for the younger clients, increasing parental involvement, if that's safe and appropriate, to help them observe the boundaries, to help them stay on task and to help make the session more productive. I think young folks are pretty zoomed out these days, and we are seeing kids just really tired in the milieu. Again, neuropsychological assessment, the questions we would be asking, again, relating to permissions and licensing and norms of these measures. So few of them really are adapted currently to online administration. We're going to definitely be negotiating the necessity of a physical exam in complement to the assessment that we're doing. many folks are doing in-person neuropsychological assessments, but they're doing the feedback sessions over telehealth, which I think is a really obvious, nice fit. But I think we need to watch the marketplace, because right now, as I say, more and more people are doing telehealth, unprecedented amounts of telehealth. So we just want to think about these organizations that are really trying to bring us new markets in a meaningful and fast-paced way. Okay, so Dr. Impossible has a forensic assessment case for parental fitness. She wants to look up, she wants to figure out the best thing for this young person and the best living situation. However, the family is currently all quarantined together in one home, and there are pretty significant academic impacts, for this young person. They used to really be thriving in school, and now they're really struggling in the online milieu. Some considerations that Dr. Impossible would want to think through would be whether or not courts are opened or closed in her jurisdiction. How stable is this living situation? They're quarantining together. Is that the plan long term? Did this disrupt some other living situation? How do they feel? Is it beneficial or not? Would her assessment be likely to withstand the other parent's attorney's review? What is the current school configuration? Will the child be returning to in-person school or not? And again, is delay appropriate? Is there emergency over anyone's safety, or are they able to delay? Termination. So termination occurs for diverse reasons. Could be the clients don't like the technology, could be, we feel they would be better served by someone else, could be we've done our work and it's time to end. When we need to refer, however, we want to think about area resource referrals. And I think in each of your areas, I encourage you to find out if there are people, delivering in-person care, know those folks. And if there are people delivering telehealth care, knows those folks. Having options of both modality, I think, is really helpful. But getting to know your telehealth community is a great opportunity, for consultation and for other reasons as well. When clients are seeking to terminate, there's this great question that Brian asked about, well, what if, they're terminating due to the modality? And this, I do think, gets sticky. And I've said this previously, so I won't belabor it, but I think it's up to us to really pause and wonder, okay, of course the client has a right to receive the care as they want to receive it, but what do we think is clinically in this person's best interest? Is it safe for them to discontinue care at this time? Do we think this has any element of avoidance, or is this just how they prefer to receive their care? And I think in this moment, we are the professionals that they came to see, and we offer our recommendations, whether it is care conclusion, whether it's referral to another provider, or whether it's continued to try to work out some of the things going on in the clinical relationship. Dr. Venture has a client treated for comorbid benzodiazepine use and an anxiety disorder. The client does not like the modality. The client's really frustrated. Some considerations that Dr. Venture will want to think through. Is there a referral available for this client? And what is the client's willingness to, receive care another way? Is it an option? What is the medical safety for this client to do that, or the medical safety of the area that they live in, the jurisdiction? Does the client have legal involvement? Are they required to receive care? And what is your clinical judgment? What do you think is in this person's best interest? And, can you describe that in a forthright manner? Okay, this is our next time to take a pause and maybe answer a few questions. And maybe, David, we could do about 10 minutes of questions, and then we'll finish up the last of our slides.
Here we go. I figured out how to unmute myself.
All right.
Success. Peg asked early on when we started this section, can we get an ASH 25 safety document for telehealth services?
That's a great question. Unfortunately, since I didn't publish it, I'm not allowed to give it out. But I will. Okay, I'm gonna say something, and you didn't hear it here.
Okay.
If you go on to Amazon, because I believe it is published as an appendix in a book that Peter Shore wrote with Peter Turk. I have a chapter, and I think it's called Clinical Video Conferencing, I think is the name of the book. But one of the chapters has the ASH 25. And technically speaking, if you go onto Amazon.com and you were to look up that book and you were to look in the appendix in that, look inside kind of feature that Amazon has, it is there.
Okay, thank you, Sarah.
The book's great.
Buy the book.
Buy the book. If you're not gonna, there is this hack.
One person said that great great problems with virtual communication, and it sounds like a technical problem. For example, on Skype, the person can see them, but they haven't been able to figure out how to get the person to hear them.
Hmm. I mean, the question I would have is this a problem with all clients or just this one client? If it's just the one client, my strongest suspicion is it has something to do with their microphone on their computer.
Yeah.
But, this is a great example of where, if troubleshooting this and if being the tech support on this becomes onerous, all clients I see. If it's, then I would want to know something about the receptive volume on your computer, and I would cross-reference it with another video conferencing product. Because if another video conferencing product is working just fine for you, then it's something about the Skype configuration. And again, you could dive deep into the configuration of your Skype account and check on all these things. At the end of the day, you can also do your audio over the phone, and add the video augment. But I would think that if it is the Skype product, I'm not familiar. I've seen this on Zoom, but I haven't seen it on Skype. That would be a good one for customer service for Skype. And usually a good company is going to have a live human who can help you. And so that'd be exactly the type of question I'd want their customer service to troubleshoot with me.
Okay. Yeah, it kind of makes sense. You almost, check the equipment, the hardware, and then go and check the software.
Most often the hardware has been my anecdotal experience. It certainly doesn't mean it's always the hardware. But if it's just on one product and not on another product, then that's probably the software, in which case it probably has something to do with the account configuration. You can always look it up. I personally would go to YouTube and say can't hear on Skype or something like that and see what comes up. But failing that, if nothing obvious comes up, get an appointment with one of their support staff and see if they can walk you through fixing it.
Cool. Here's another question for you, Sarah. What about translation services during a telehealth session?
It's a great question. And I think this is a great application of multi-call. So as we talked about in the last class, I think this is where the products for healthcare kind of fall down and the products for business stand up, in terms of the ability to handle more than 2 callers at a time. I do think the business products kind of shine, but it's a nice example of how we can have an interpreter join a session. Of course, we do have to have adequate consents and releases of information and so on and so forth. But assuming all that paperwork's done, we can have them join in a translational capacity. That being said, there are software programs that do that. I have not seen them integrated into video conferencing. That doesn't mean that they aren't. I'm just not aware of them. Most of the translational software that I'm most familiar with happen on smartphones. So the question is how to get that integrated, and I don't know the answer.
Okay. Well, that was it for the questions. One person asked if you could please give the name of the book one more time. I'll type it in while you're saying it.
Oh gosh,
Authors.
I believe it's called the authors. The editors. I can tell you that. The editors are Peter Shore, Shore, and Peter Turk, Tuerk. Both named Peter. And I believe it is called, I'm just going to look this up quickly so I don't shame myself. I believe it is called Clinical Video Conferencing. Yes, clinical video conferencing. Look at that.
Okay. All right, great. Thank you.
In telehealth, I believe, is Clinical Video Conferencing in Telehealth. And it's a great book. I have a chapter in there. Buy their book. And if you don't, go to Amazon. All right.
Thank you.
Building your telemental health practice. So in thinking through, many of us maybe started off doing this, or our agency required us to do this. And in early days, it was really just about, getting those existing clients and getting them up and running with telehealth. And it was kind of a wild dash. Many of us may live in jurisdictions that are reopening or have opened or about to open. I think many of us might be asking a question: what does this look like in my professional life now? Will telemental health have a role to play for me? And am I going to have it stick around? And here's where I think we can start making the shift from, having sort of makeshift solutions, for the short term, and investing in longer term solutions that will really help us cultivate a good practice that we enjoy. I always think about the role of physical space. I know this is something we really dove into last class, but, do you have a space to do this? And again, in the short term, we can make it work. We can figure this out. We can commandeer the kitchen, for several hours daily. We can do what we need to do. But in the long term, am I going to have a space that feels professional, that is quiet, that I cannot be interrupted, and that I'm, of course, these are all requirements always for HIPAA, but is it a place that is physically comfortable and that I can really see myself doing this in the long run? Where will I get my referrals? How can I, figure out how I want to advertise this practice? There are many national registries. Psychology Today actually now has this entire new advertising function that highlights video conferencing. I think that's nifty. But your state organizations will often have registries. Many of our professional organizations will have registries. Thinking through, how do I want to advertise? Many people elect to have a professional website for their practice that focuses on the services they offer. And, some folks decide they want to pay for online advertising, Google ads, things like that. It's personal choice. But thinking how we're going to reach those clients and get those referrals. Personally, I like to cultivate relationships with referral sources. And we'll talk a little bit more about that in a moment. Documentation. Again, in the beginning, we're making do, we're doing our best. But I really, as we move forward, really taking some time to go through and make sure we have a telemental health consent form that we like, an emergency plan that we like, an appropriate client appropriateness assessment, document that we like and that we've been thoughtful about, that we have this documentation, we've invested our time, and we're really ready to move forward in a meaningful way. And of course, training and consultation. Who are you going to talk to? Who are those other telehealth providers? And how can you have a community to talk about cases that are challenging? Advertising. So there's lots of different ways we can be advertising the practice. I mentioned practice website. I mentioned additional ads we can buy or national registries. I think my best referral sources, and I wonder what other folks would say, have been some of these national registries like Psychology Today, but also relationships in the community I wish to serve. I've done a fair bit of outreach, as a telemental health provider, reaching out to areas in my state that I know to be underserved that I think could benefit. As somebody who offers SUD services, I have at times, reached out to inpatient treatment programs or partial hospitalization programs or other areas that I think would do well to have a good collaboration with outpatient care providers in the community. And I have to say, some of those folks have become my tried and true referral sources. So really getting those relationships, and investing in them. I'll usually send a thank you note when they send someone to me. I don't put any PHI, I don't indicate what client I'm talking about, but I'll simply send a thank you note in the beginning days anyway of saying, thank you for referring to my practice. I just leave it there and I put a business card in it. And this really, starts to get into outreach. I think if you're going to have a telemental health practice, getting comfortable with doing some outreach, great, outreach targets, include primary care, specialty clinics. I think for SUD, being thoughtful about those organizations or community that offer good SUD care, perhaps medication-assisted opioid care. What are the community organizations? NAMI is a great one. Being known to NAMI is a good thing. And I always consider offering free psychoeducation to membership. I actually have a colleague who I connected with my child's school, and he's doing a webinar this evening on, children and anxiety, because that's his area of specialty. And I think it's a really smart thing he's doing, because he's going to be out there offering good free psychoeducation to parents, but he's also now going to be someone that those folks think of when they're looking for care. And I think it's a smart thing to do. It's good for public health. I think it helps contribute to good education in our communities, but then also, it's kind of free advertising and outreach and gets your practice known as a telehealth provider. Again, physical space. What do we want for the future of our offices? I've had lots of folks in the last few weeks say, oh, great, I don't have to rent an office anymore. This is liberating. And I really have a very different attitude toward this. I will say I like to have office space. Again, there is no data-driven reason to say we cannot manage emergencies remotely. We cannot do assessments, some type of assessment and intake remotely. But I personally just like to have that physical space. If I had a forensic focused practice, if I had a practice that did do formal assessment intakes with a specific referring question, I would definitely want that physical space. I think we have to think about the jurisdictional requirements of where you live. Again, especially with some of these executive orders, they're going to expire eventually. So maybe now I'm not required to do my intake in person, but that might change, in the coming months. So before we all give up our commercial leases, I would encourage us to be thoughtful about the theme that physical space will have long run. I would not be surprised if this doesn't look different in the future. If we don't see folks, instead of having, 5 days in an office, having less, if we don't see folks having telehealth days and in-person care days, I anticipate that will be the shift in the direction it goes. But at the end of the day, I like having a physical space, because if I determine that telehealth is not appropriate, I feel safe to do so, my client feels safe to do so, then having that option of in-person care, especially as we reopen and we, start getting back to normal, I think is going to be a valuable thing. Technology investment. So I do think that there's a saying, you get what you pay for. I think that I do like a lot of the free products, actually, but I think that if we're going to have telehealth meaningfully in our practice for the long run, thinking about investing in those products that are designed for healthcare, a really good video conferencing program, maybe a document transfer, some sort of secure email or secure messaging program, maybe having our own telephone line, a mobile device, that is just for our clients. Do we want to invest our time and money into transitioning to an electronic medical record if we don't already deliver care this way? I think that these are going to be investments that are meaningful to our practice, especially if we have a telehealth focused practice, and going to really allow it to flourish and grow and be a mainstay of our clinical work. Okay, administrative staff. Many of us may have administrative staff that work in our practice or support us in some way, either through the agency we work for or through our independent practice offices. And I think there is this opportunity to integrate administrative staff into the use of telemental health. I've seen this done especially well in medical practices that have one treatment room for the patient. So the patient's hanging out. When I go see my daughter's pediatrician over telehealth now, I'm hanging out in my treatment room. And, the medical assistant comes in via telehealth and asks us all those usual questions about, how things are going and why we're here and so on and so forth. Then they will leave that video call, and then it's darkness again. And then the doctor will come on and we'll have our meeting. I think this is really a nice way to involve administrative staff and actually use clinician time to the best possible way. I think it gets a little tricky administratively, but many electronic medical records and video conferencing products will have what's called an administrative login. Basically, it allows another party to log in, and they have to complete, a HIPAA documentation that says they're going to be a good actor, just as you did when you signed that BAA. But basically, it allows them to have limited permissions. So, they can come in, they can participate in a call, but there may be other features like prescribing drugs, that they're not allowed to do, or, scheduling new appointments they may or may not be allowed to do. So it kind of articulates what they can do and what they can't do on the product. And I think it's a clever augment that these products have. So when we're having our administrative staff, join a telemental health call, some things we want to think through in advance include, what do we want them to accomplish? What is the goal of bringing them into this video call? Do we want them to collect measures? Are there some sort of assessment questions we want them asking so that I can have that in advance of the meeting? Do we want them to do things like confirming privacy, making sure the client's alone in the room, making sure that visibility is good, that they can be heard easily? Do we want them reviewing some of the risks and benefits of the modality, as we do in the informed consent process? Would this be something that would help have our administrative staff be good partners in? Okay, just a little demonstration of what that might look like. Hi, Mr. Barnwell. My name is Sarah, and I'm Dr. Smith's assistant.
Hello.
Well, thank you so much. I appreciate your coming today to see Dr. Smith via telemedicine. I am here to check you in for your appointment, much like you would in our office, but today we're going to do this virtually.
Very cool.
To start off, I'm going to check in. Can you hear and see me okay?
Yes, I can.
Great. Okay. I see in your chart that you completed the informed consent for telehealth. Thank you for doing that. I know you had completed an informed consent when you'd come into our office previously, but this is a special document that talks about some of the risks and benefits specifically of seeing Dr. Smith over telehealth. Dr. Smith will go over this document with you, but are there any basic questions that I might be able to answer?
No, I don't think I have any right now.
Okay. I see also that you completed your emergency contact information and emergency plan in case Dr. Smith were need to send help to you remotely. I want to double check that you are at your home at 123 Skinner Street.
That's correct.
Okay. And I have your phone number as 555-867-5309. Is that correct?
That is also correct.
Great. And this is information that Dr. Smith would need in case of an emergency. So if you have any changes, if you move or get a new phone number, perhaps more simply, please do let us know when we do these check-ins. Okay. I have your insurance as Blue Cross Blue Shield of Washington. Is that still accurate?
That is still correct.
And it's our intention to bill this to insurance today. Thank you for completing the necessary forms to allow that. I know that Dr. Smith wanted you to complete both the PHQ and the GAD form, the GAD form. Did you happen to have a chance to complete those?
I think I completed the PHQ. I don't think I've completed the GAD yet.
It's no problem. So I'm going to send you a link right now to the online portal that you use to complete the PHQ, and you're going to use that same portal to complete the GAD, and then that way Dr. Smith will have that information for your appointment today.
Got it. I'll do that right after this. Great.
Just while you're waiting, you'll probably have about 4 or 5 minutes. So,
perfect.
Okay. I see the door closed behind you. Just want to make sure you're alone in the room and cannot be overheard today.
Correct.
Great. Okay. Well, we're all checked in. Any questions for me?
No, not at this time.
Okay. Well, what's going to happen now, Mr. Barnwell, is I am going to leave the line, and you're probably going to be here about 4 or 5 minutes. It's going to go dark. Don't worry. Dr. Smith is coming. She's running about 5 minutes behind today of her schedule. It happens sometimes in clinic. So she will be here. She'll come in just as I did. You don't need to do anything. Just hang out here. And if you want to kill some time, feel free to complete that GAD.
I'll get right on it.
All right. Thanks, Mr. Barnwell. Okay. So some considerations specific to telemental health in the context of coronavirus. Again, as we transition, many of us from a short-term horizon on telemental health to a longer term, we're thinking less about existing clients, although hopefully we're still thinking about them, and more about new clients, intakes, and adapting our practice as we invest in a longer-term sustainable structure. This is the difference between something we're doing temporarily, in a national emergency and health crisis versus a practice that we really want to continue to offer and invest in and have be with us. I think this is, for me, and we've talked about many different facets of it, but the last thing I really want to talk about is there is this opportunity / caution I would talk about in terms of finding balance, because, the realization that we can have additional billable hours, that we can, for some of us, maybe we don't have to pay for rental space, while we do these telehealth hours, or, perhaps there's some sort of financially advantageous way to approach this. I think it's great and is good for the health of our businesses. Simultaneously, I think there is this question about self-care. I know when I was at the VA hospital, they had, several wonderful initiatives about bringing telehealth more into the mainstay, and they went to all the clinicians and said, okay, now all of you are going to be offering telehealth to these clients that live in farther out regions, which I thought was great, and that's exactly what we want to be doing. And they in no way reduced our panels otherwise. So, in addition, we had all had full, I think 32 hours a week of client care, and then in addition, supervision and meetings and all the things that come with your job. But now we were also to see clients remotely. And there was this question of, well, hold on, how are we going to do this and do this well? So, especially if I'm transitioning back to in-person care and I'm planning on having the same number of hours, adding telehealth can be great. But I really want to encourage everyone to prioritize self-care and to think about balance and really make sure that we're not burning ourselves out and using this as a tool to really load on more and more work without the confines of physical space rental. So in summary, in synopsis of the themes we have talked about today, when we are selecting our clients, we determine and document what criteria, are going to be relevant for our practice, how we want to practice over telemental health. What services do we want to offer and to who? and acknowledging this assessment will be an ongoing process. The client or I may decide this isn't a good fit at any time. When we're conducting those initial intakes, we try to collect as much information as we can beforehand. We're slowing that pace and asking lots of questions, maybe relying a bit more on structured interviews that help us think of all the questions, we might not usually ask, with a strong focus on rapport, which can really be challenged in the modality. So that's going to be our biggest goal for those intakes. I think even more than getting every intake question answered for me, I am really focused on establishing a relationship with this client. When delivering assessments or working with special populations, we're going to try to use the appropriate online assessment when it's available, when it's possible. We're going to think through the practical considerations about the adaptability of the measure, norms available for the measure, and legal permissions to use the measure remotely. Sometimes we may abbreviate our batteries, taking out the ones that just don't work and leaving the ones that do. And some assessments may need to be delayed because of practical concerns or because the referring question is just no longer relevant in the current world context. When terminating with a client, we think through, we know our referrals and think about where we can send them. Contemplate themes of avoidance. To what extent do we think this is clinically relevant versus just, not a fit for the client? Both are valid. And we offer our opinion. I think that that's just really letting folks know this is what I think would be in your best interest, and then respect their decision, of course. As you're building a telemental health practice, we're advertising, we're reaching out, we're networking, and we're really thinking about where those good referral sources will come from. We invest in sustainable technologies, that we can use over time, that comply with HIPAA, that are designed for healthcare. We think about the role of physical office space. How much do we need, and what's that going to look like in our practice? We really get to know our jurisdiction. What are those executive orders that have changed how telehealth works, and how long do they stick around? Because eventually they'll expire. We train our staff to know how to use our technology. I have a really kind of funny story where I consulted with a practice in Los Angeles where I lived for many years, and they had someone who worked there, and they were at their job, and they were, as is the case in Los Angeles, they had many famous folks coming and going, and this person happened to see someone famous come into the psychotherapy practice, and they of course knew that they would never go onto any sort of, technology format and talk about seeing someone at work. However, they did get on social media that had a live video chat, sort of a public-facing video chat, and they said, "Oh, I just saw, my favorite actor so-and-so, isn't that cool?" Said that to all their friends. Now, they didn't disclose where they saw them, and we could argue this was never a good idea, but technically they didn't break the rules, except they had enabled GPS, on their social media. And in that moment, it dropped a pin and said, Jones's psychotherapy practice. Well, now they've just disclosed that they saw the actor, Jones's psychotherapy practice, which of course is a HIPAA violation. So, when I'm talking about training our staff, I don't mean just on those technologies that we'll be using, but I think there's this opportunity to train them more broadly in their technology use, both in work and out, to make sure that they are observing good boundaries and good PHI protection. Okay. That's a good question. Some previously submitted questions. I'll go sort of quickly because I know we're getting to the end of our time. Templates. Folks have asked for, where can I find good telepsychology templates and return to in-person care informed consent templates? I think I mentioned earlier, I like APA's templates as well as the trust insurance. So here are some links. You'll have access to these slides later on, but if you want to take a screenshot, I'll leave it there for a moment. I think they both offer really nice informed consent for telepsychology and return to in-person care. I received a great email that talked about this one-page, excuse me, I had several people ask questions about where can I get a one-page handout. And I wanted to mention that Samsha has a great handout, which I'm going to go to a picture of in a moment here. And then many electronic medical records actually have a one-page handout for helping your client adapt to telemental health. I myself have created one. If you're interested, you're welcome to email me. I'm happy to send it to you. But basically, it's a one-page document that goes over, this is what you can expect. This is how my electronic medical record will send you the invitation. It's just something you can send to a client that outlines those expectations. This is in addition to the informed consent document. Again, many EMRs are going to have this simple practice. The one I use has it. And then, of course, SAMHSA, I think, offers this snazzy, and I think David showed this to me, how to prepare for your video appointment with your mental health clinician handout. This can be found on the SAMHSA website, or of course, you're welcome to take it from the slides today, however you can get it. Okay, well, I think we're about at that time. So David, I don't know, is there enough time for any other questions, or should we start with our housekeeping?
Well, Sarah, you had a couple of comments, but we didn't have any more questions except for the ones that were left over from earlier today.
Okay.
How about if I read one of the comments and then we can start to move towards the business?
Sure thing.
Okay. Peg noted, as an NGO that is dependent on grants and contracts, we are now at the point where funders want to know if we have implemented telehealth and are utilizing best practice policies and procedures.
That's a great point. And I think, the more we can point to those guideline documents, so the more it says, yes, I'm using a telehealth platform that is HIPAA compliant, that's given me a business associates agreement. I've read my APA telepsychology guidelines. I've read my ATA, American Telemedicine Association, best practice for video conferencing documents. The more we can kind of point that we're aware of, these policy and guideline documents, I think it's a meaty, satisfying answer to them.
Yeah. And one last note is that people commented, Jen in particular said, I think confirming a client's information is so important, especially where they actually are and not assuming location.
Yes, I always think of this one time I asked a client, are you home? And they said, oh, yes. And then, and this was for a telephone visit, and then I heard their children fighting in the background over Bluetooth, and they were driving them for ice cream. Like,
oh my God. Okay.
So I think, there's this issue of asking, and then there's, trust but verify, I suppose.
Yeah. Well, that's it for the comments. No more questions came through.
Great. I'll remind folks that if they have questions later, or there's, something they want to chat about, please don't hesitate to send an email to nwattctelehealth@gmail.com. That's an email that I'll be monitoring. And, I use some of the emails from that account to populate the That's a Good Question section of the talks.
Fantastic. I copied and put that in the chat box for folks, so it might be easy for them to grab that. And I guess the last housekeeping item is a request to all of our participants today. If you would please fill out the survey that I put in the chat. It will also come to you tomorrow in the follow-up email, and you can fill it out there too. It only takes about 1 minute to complete, so it's not a very long one. And your attendance today, we have your contact information to send you a certificate of completion. And with that, we're down to saying goodbye, and a big virtual thank you to Sarah for your very informative presentation today.
Well, thanks so much, David. Thanks so much to everyone who came, and thank you to NWATTC. It's a great team, and I really appreciate your having me.
Wonderful. And look forward to seeing you all on June 2nd. The next topic is clinical engagement and telemental health. And with that, I think we are now closing. So thank you all for attending today.
See you next time.
Thank you, Jennifer.